Question 1. A 68-year-old male presents to the emergency department with altered mental status, small respirations, and a fruity odor on his breath. His blood glucose is 780 milligrams per deciliter, and his arterial blood gas, ABG, reveals pH 718, PaCO 228 millimeters of mercury, HCO 312 milliequivalent/L. Which of the following is the most immediate nursing priority?
A.
Administer intravenous regular insulin.
B.
Prepare for intubation and mechanical ventilation.
C.
Initiate a continuous infusion of 0.9% normal saline.
D.
Obtain a stat electrocardiogram, ECG. Answer. C. Initiate a continuous infusion of 0.9% normal saline. This question tests your understanding of diabetic ketoacidosis, DK management, and the most immediate nursing priority. The keywords altered mental status, small respirations, fruity odor, and the ABG indicating metabolic acidosis with compensation, along with a very high blood glucose, point directly to DKA. The most immediate priority in DKA is aggressive fluid resuscitation with 0.9% normal saline to correct dehydration and improve renal perfusion, which helps facilitate the excretion of glucose and ketones. While insulin is crucial, it is typically started after initial fluid resuscitation to prevent rapid shifts in fluid and electrolytes, and intubation is not the first line unless respiratory failure is imminent. Obtaining an ECG is important, but not the most immediate life-saving intervention. Prioritizing fluid resuscitation helps stabilize the patient's hemodynamics and prepare their body for the subsequent administration of insulin. Question 2. A nurse is caring for a patient with acute respiratory distress syndrome, ARDS, who is on mechanical ventilation with a PEEP of 15 cmH2O. The nurse notes a sudden drop in SpO2, unilateral absent breath sounds, and tracheal deviation to the unaffected side. What is the most appropriate initial nursing action?
A.
Increase the FiO2 to 100%.
B.
Auscultate bilateral lung fields for adventitious sounds.
C.
Prepare for immediate needle decompression or chest tube insertion.
D.
Administer a rapid-acting bronchodilator. Answer. C. Prepare for immediate needle decompression or chest tube insertion. This question evaluates your ability to recognize and respond to a tension pneumothorax, a life-threatening complication in mechanically ventilated patients, especially those on high PEEP. The key clues are a sudden drop in SpO2, unilateral absent breath sounds, and, critically, tracheal deviation to the unaffected side, which are classic signs of a tension pneumothorax. This condition causes significant hemodynamic compromise by compressing the vena cava and heart and requires immediate intervention to relieve pressure. While increasing FiO2 and auscultating are important assessment steps, the clinical picture demands a rapid, emergent intervention like needle decompression or chest tube insertion to save the patient's life. Recognizing the triad of symptoms for a tension pneumothorax is crucial for prompt action. Question 3. A patient with cirrhosis develops hepatic encephalopathy. The nurse should anticipate which medication order to reduce ammonia levels?
A.
Furosemide.
B.
Lactulose.
C.
Spironolactone.
D.
Metoprolol. Answer. B. Lactulose. This question assesses your knowledge of hepatic encephalopathy management. The concept being tested is how to reduce ammonia levels, which are elevated in hepatic encephalopathy due to the liver's inability to metabolize ammonia into urea. Lactulose is the medication specifically used for this purpose. It works by decreasing intestinal ammonia production and promoting its excretion in the stool. Furosemide and spironolactone are diuretics used to manage fluid overload, and metoprolol is a beta blocker used for variceal bleeding prophylaxis, none of which directly address ammonia levels. Remember that lactulose helps trap ammonia in the gut and expel it, improving mental status. Question 4. A patient in the ICU post-cardiac arrest is receiving therapeutic hypothermia. The nurse understands that which of the following is a primary goal of this therapy?
A.
To prevent deep vein thrombosis.
B.
To reduce cerebral metabolic demand and minimize secondary brain injury.
C.
To accelerate the metabolism of sedatives. D. To improve cardiac output and blood pressure. Answer. B. To reduce cerebral metabolic demand and minimize secondary brain injury. This question tests your understanding of the primary goal of therapeutic hypothermia following cardiac arrest. The main concept is neuroprotection. Therapeutic hypothermia works by lowering body temperature, which in turn reduces the brain's metabolic rate and oxygen consumption, thereby minimizing neuronal damage and improving neurological outcomes after a period of ischemia and reperfusion. While other benefits might indirectly occur, the core purpose is brain protection. It's not primarily for DVT prevention or speeding up sedative metabolism, which would actually be slowed by hypothermia. Think of cooling the brain as putting it on a rest mode to protect it from further damage. Question 5. A nurse is assessing a patient with a traumatic brain injury, TBI, and notes a Glasgow Coma Scale, GCS, score of 7, pupils 6 millimeters bilaterally and sluggish, and decorticate posturing. The nurse should anticipate which intervention?
A.
Administration of intravenous fluids at a keep vein open rate.
B.
Insertion of a nasogastric tube for feeding.
C.
Preparation for placement of an intracranial pressure, ICP monitoring device.
D.
Encouraging frequent family visitation to stimulate the patient. Answer. C. Preparation for placement of an intracranial pressure, ICP monitoring device. This question tests your ability to recognize signs of severe neurological deterioration and anticipate appropriate interventions for traumatic brain injury. A GCS of 7, sluggish and dilated pupils, and decorticate posturing are all critical indicators of severe neurological impairment and potential increases in intracranial pressure. Monitoring ICP is essential for guiding management and preventing further secondary brain injury. While other interventions might be necessary at some point, establishing ICP monitoring is the priority, given these critical findings to assess and manage brain swelling effectively. These signs strongly suggest significant intracranial pathology that needs direct monitoring. Question 6. A patient is admitted with a severe gastrointestinal bleed, presenting with hypotension, BP 80/40 millimeter of mercury, tachycardia, HR 125 BPM, and decreased urine output. After securing 2 large-bore IVs, what is the most appropriate initial fluid resuscitation strategy?
A.
Infuse 500 milliliters of 5% dextrose in water, D5W, over 30 minutes.
B.
Administer a rapid infusion of 0.9% sodium chloride.
C.
Transfuse 2 units of packed red blood cells, PRBCs, immediately.
D.
Prepare for administration of albumin. Answer. B. Administer a rapid infusion of 0.9% sodium chloride. This question assesses your understanding of immediate fluid resuscitation in hypovolemic shock due to a severe GI bleed. The critical keywords are hypotension, tachycardia, decreased urine output, and severe gastrointestinal bleed, indicating significant fluid volume deficit and hypovolemic shock. The most appropriate initial fluid is an isotonic crystalloid solution like 0.9% sodium chloride, administered rapidly in boluses to restore intravascular volume and improve perfusion pressure. While PRBCs are eventually needed to replace lost blood, crystalloids are the immediate priority to fill the vascular space and support vital organ perfusion while blood products are being prepared and cross-matched. D5W is hypotonic and will not stay in the intravascular space effectively, and albumin is not the first-line resuscitation fluid. Question 7. A patient with severe sepsis develops acute kidney injury, AKI, with anuria and fluid overload. The nurse anticipates which renal replacement therapy will most likely be initiated?
A.
Intermittent hemodialysis.
B.
Peritoneal dialysis. D.
C.
Continuous venovenous hemofiltration. CVH.
D.
Plasmapheresis. Answer. C. Continuous venovenous hemofiltration. CVH. This question tests your knowledge of renal replacement therapies, specifically in the context of a critically ill patient with sepsis and AKI. The keywords severe sepsis, anuria, and fluid overload highlight the patient's critical condition and hemodynamic instability. Continuous renal replacement therapies, CRRT, like CVVH, are generally preferred in hemodynamically unstable patients because they provide slower, continuous fluid and solute removal, minimizing rapid fluid shifts and cardiovascular instability, often seen with intermittent hemodialysis. Peritoneal dialysis is less common in acute critical care, and plasmapheresis is for plasma exchange, not primary renal replacement. CVVH allows for better hemodynamic tolerance, which is vital in sepsis. Question 8. A nurse is caring for a patient on mechanical ventilation who suddenly becomes agitated and begins fighting the ventilator. The high-pressure alarm is sounding frequently. Which of the following is the nurse's priority action?
A.
Increase the sedation infusion rate.
B.
Assess the patient's airway and ventilator circuit for obstructions or disconnections.
C.
Request a stat arterial blood gas, ABG, analysis.
D.
Manually bag the patient with 100% FiO2. Answer. B. Assess the patient's airway and ventilator circuit for obstructions or disconnections. This question focuses on immediate troubleshooting for a mechanically ventilated patient experiencing distress. The critical keywords are agitated, fighting the ventilator, and high-pressure alarm sounding frequently. These signs strongly suggest a problem with the patient-ventilator interface or the circuit itself, such as a kinked tube, biting the ETT, secretions, or pneumothorax. Before administering more sedation or requesting an ABG, the nurse must ensure airway patency and proper ventilator function, as this is an immediate life-threatening concern. Manually bagging the patient might be necessary after initial assessment if the problem cannot be quickly resolved, but the first step is to identify the cause. Question 9. A patient with a history of heart failure is admitted with acute decompensated heart failure. The nurse notes crackles bilaterally jugular venous distension JVD and AS3 heart sound. Which medication order would the nurse question if given initially?
A.
Furosemide.
B.
Morphine sulfate.
C.
For fluids at 150 milliliters per hour.
D.
Oxygen via nasal cannula. Answer. C. For fluids at 150 milliliters per hour. This question evaluates your understanding of managing acute decompensated heart failure. The keywords crackles bilaterally, JVD, and S3 heart sound all indicate fluid overload, which is characteristic of acute decompensated heart failure. Administering intravenous fluids at 150 milliliters per hour would exacerbate the fluid overload and worsen the patient's condition, making it an inappropriate initial order. Diuretics like furosemide, oxygen, and morphine to reduce preload and anxiety are all common and appropriate interventions in this scenario. Your critical thinking should flag anything that adds to the volume in an already volume-overloaded patient. Question 10. A patient is admitted with a subarachnoid hemorrhage, SH. The nurse understands that which of the following complications is a major concern in the days following the initial bleed?
A.
Deep vein thrombosis, DVT. B. Hydrocephalus.
C.
Vasospasm.
D.
Seizures. Answer.
C.
Vasospasm. This question assesses your knowledge of common complications following a subarachnoid hemorrhage, SH. The concept being tested is understanding the timeline and specific risks after SH. While DVT, hydrocephalus, and seizures can occur, vasospasm is a highly significant and common complication that typically develops 3 to 14 days after the initial bleed, leading to delayed cerebral ischemia and potentially devastating neurological deficits. Nurses must vigilantly monitor for signs of vasospasm, such as new neurological deficits, and manage it with therapies like nimodipine and Triple H therapy. This specific delayed complication is a hallmark of SAH recovery. Question 11. The nurse is caring for a patient with septic shock receiving norepinephrine. The patient's arterial line blood pressure cuff reading is 70/45 mmHg despite increasing the norepinephrine infusion. The patient's skin is mottled, and lactate is 6 millimoles per liter. What is the most appropriate next intervention?
A.
Increase the norepinephrine infusion further.
B.
Administer a fluid bolus.
C.
Initiate a second vasopressor like vasopressin.
D.
Prepare for intubation. Answer: C. Initiate a second vasopressor like vasopressin. This question tests your critical thinking regarding vasopressor management in refractory septic shock. The key clues are septic shock, norepinephrine, BP 70/45 mmHg despite increasing norepinephrine, mottled skin, and lactate 6 millimoles per liter. This indicates persistent hypoperfusion and shock that is refractory to a single vasopressor. The most appropriate next step is to add a second vasopressor with a different mechanism of action, such as vasopressin, to achieve adequate mean arterial pressure and improve organ perfusion, rather than simply increasing a potentially maxed-out norepinephrine dose. While fluid status should always be assessed, adding a second vasopressor is often necessary when maximum first-line vasopressor doses are insufficient. Question 12. A patient with a history of diabetes mellitus is admitted with acute pancreatitis. The nurse should monitor for which electrolyte imbalance as a common complication?
A.
Hypernatremia.
B.
Hypokalemia.
C.
Hypocalcemia.
D.
Hypermagnesemia. Answer: C. Hypocalcemia. This question assesses your knowledge of electrolyte imbalances specifically associated with acute pancreatitis. The key concept is understanding how pancreatitis affects calcium levels. In acute pancreatitis, digestive enzymes, particularly lipase, are released and can cause fat necrosis in the abdomen. The fatty acids released during this process bind with serum calcium, forming soaps, which effectively sequesters calcium and leads to hypocalcemia. This can be a significant and life-threatening complication, so vigilant monitoring is crucial. While other imbalances can occur, hypocalcemia is a classic and important finding in acute pancreatitis. Question 13. A nurse is assessing a patient with a spinal cord injury at the T6 level who suddenly develops a throbbing headache, profuse sweating above the injury level, and a blood pressure of 200/100 mmHg. What is the priority nursing intervention?
A.
Administer an analgesic for the headache.
B.
Elevate the head of the bed to 90 degrees.
C.
Administer an immediate dose of a rapid-acting antihypertensive.
D.
Search for and remove the noxious stimulus. Answer: D. Search for and remove the noxious stimulus. This question tests your recognition and management of autonomic dysreflexia in a patient with a high spinal cord injury. The critical keywords are T6 level, suddenly develops a throbbing headache, profuse sweating above the injury level, and BP of 200/100 mmHg. These are classic signs of autonomic dysreflexia, a medical emergency triggered by noxious stimuli below the level of injury. The priority is to identify and remove the stimulus, for example, full bladder, fecal impaction, tight clothing, to resolve the hypertensive crisis. While elevating the head of the bed is also important to lower BP, and antihypertensives may be needed if the stimulus cannot be removed quickly, finding and removing the cause is the definitive action. Question 14. A patient is receiving continuous renal replacement therapy (CRRT) with citrate anticoagulation. The nurse should be vigilant for signs of which electrolyte imbalance related to the citrate?
A.
Hypernatremia.
B.
Hyperkalemia.
C.
Hypocalcemia.
D.
Hyperphosphatemia. Answer: C. Hypocalcemia. This question tests your specific knowledge about the complications of citrate anticoagulation used in CRRT. The concept being tested is that citrate, an anticoagulant, binds with ionized calcium in the patient's blood to prevent clotting in the CRRT circuit. While most of this citrate calcium complex is removed by the filter, some returns to the patient and is metabolized by the liver. However, if the patient's liver function is impaired or the citrate load is too high, it can lead to systemic accumulation of citrate and subsequent binding of the patient's own ionized calcium, resulting in hypocalcemia. Therefore, monitoring ionized calcium levels is critical. Question 15. A nurse is preparing to administer packed red blood cells to a patient with a hemoglobin of 6/8G/DL. Before starting the transfusion, what is the most critical action?
A.
Obtain a signed consent form for transfusion.
B.
Administer an antihistamine to prevent an allergic reaction.
C.
Verify patient identity and blood product against the physician's order with another registered nurse.
D.
Prime the blood tubing with 0.9% normal saline. Answer. C. Verify patient identity and blood product against the physician's order with another registered nurse. This question emphasizes patient safety and the critical steps before blood product administration. The keyword most critical action highlights the importance of preventing an ABO incompatibility reaction, which can be fatal. Verifying patient identity and cross-checking the blood product information, type, RH, unit number, against the physician's order and the patient's armband with another registered nurse is a mandatory, non-negotiable step to ensure the correct blood is given to the correct patient. While consent and priming are essential, they do not carry the same immediate risk of fatality as an ABO incompatibility error. This double-check process is the cornerstone of safe blood transfusions. Question 16. A patient with diabetic ketoacidosis (DKA) is receiving an insulin infusion. The nurse notes the patient's blood glucose is now 250 milligrams per deciliter. What adjustment should the nurse anticipate in the insulin and fluid management?
A.
Increase the insulin infusion rate and continue 0.9% normal saline.
B.
Decrease the insulin infusion rate and switch to 5% dextrose in 0.45% sodium chloride.
C.
Discontinue the insulin infusion and administer subcutaneous insulin.
D.
Continue current insulin and fluid rates until glucose is less than 100 milligrams per deciliter. Answer. B. Decrease the insulin infusion rate and switch to 5% dextrose in 0.45% sodium chloride. This question tests your understanding of DKA management as blood glucose normalizes. Once the blood glucose approaches 200 to 250 mg/dl in DKA, the primary concern shifts from rapid glucose reduction to preventing hypoglycemia and clearing ketones. At this point, the insulin infusion rate is typically decreased and dextrose, for example, D545NS, is added to the intravenous fluids. This allows continued insulin administration to facilitate ketone body resolution while preventing hypoglycemia. Discontinuing insulin prematurely would halt ketone resolution, and continuing without dextrose would risk hypoglycemia. Think of it as a crucial pivot point in DKA treatment. Question 17. A patient with acute respiratory failure requires positive end expiratory pressure, PEEP, of 10 cmH2O. The nurse understands that a potential complication of high PEEP levels is
A.
Increased venous return.
B.
Decreased intrathoracic pressure.
C.
Barotrauma and reduced cardiac output.
D.
Improved oxygen delivery to tissues. Answer. C. Barotrauma and reduced cardiac output. This question evaluates your understanding of the physiological effects and potential complications of positive end expiratory pressure, PEEP. While PEEP improves oxygenation by recruiting alveoli, high levels can significantly increase intrathoracic pressure. This increased pressure can lead to barotrauma, lung injury from excessive pressure, and can also compress the vena cava, reducing venous return to the heart. A reduction in venous return ultimately decreases preload, stroke volume, and cardiac output, potentially leading to hypotension. Therefore, the nurse must monitor for these adverse effects, especially with high PEEP settings. Question 18. A patient is admitted with a new-onset atrial fibrillation with rapid ventricular response, RVR, and is hemodynamically unstable, BP 85/50 mmHg, altered mental status. What is the most appropriate immediate intervention?
A.
Administer intravenous diltiazem.
B.
Prepare for synchronized cardioversion.
C.
Administer a bolus of 0.9% normal saline.
D.
Initiate a heparin drip. Answer. B. Prepare for synchronized cardioversion. This question tests your knowledge of managing unstable atrial fibrillation with RVR. The critical keywords are new-onset atrial fibrillation with rapid ventricular response and hemodynamically unstable, indicated by hypotension and altered mental status. In this scenario, pharmacological interventions like diltiazem or fluid boluses are not rapid enough or directly effective for hemodynamic instability caused by the arrhythmia. Immediate synchronized cardioversion is the definitive treatment to restore sinus rhythm and stabilize the patient's hemodynamics. Remember, instability demands electrical intervention in this cardiac rhythm. Question 19. A nurse is assessing a patient with multiple trauma admitted to the ICU. The patient has decreased breath sounds on the right, dullness to percussion, and tracheal deviation to the left. These findings are most consistent with
A.
pneumothorax, B. hemothorax,
C.
tension pneumothorax,
D.
flailed chest. Answer: B. hemothorax. This question tests your ability to differentiate between various thoracic injuries based on assessment findings. The critical clues are decreased breath sounds, dullness to percussion, and tracheal deviation. Dullness to percussion, combined with decreased breath sounds, strongly suggests the presence of fluid, blood in this case, given the trauma A in the pleural space. Tracheal deviation occurs when a significant volume of fluid or air shifts mediastinal structures. While a tension pneumothorax also causes tracheal deviation, it would present with hyperresonance to percussion due to air, not dullness. A hemothorax fits all the presented assessment findings. Question 20. A patient in the ICU on continuous sedation suddenly develops pinpoint pupils, respiratory depression, R8 breaths/min, and an SpO2 of 85%. The nurse suspects opioid overdose. What is the priority nursing intervention?
A.
Administer flumazenol.
B.
Administer naloxone.
C.
Increase the rate of the mechanical ventilation.
D.
Obtain a stat blood gas. Answer: B. Administer naloxone. This question tests your ability to recognize and manage an opioid overdose. The keywords pinpoint pupils, respiratory depression, and SpO2 of 85% in a patient on continuous sedation strongly indicate an opioid overdose. Naloxone is a specific opioid antagonist that rapidly reverses the effects of opioids. While increasing ventilation and getting a blood gas are important assessments, administering the antidote is the priority to reverse life-threatening respiratory depression. Flumazenol is for benzodiazepine overdose, not opioid. Acting quickly with naloxone can be life-saving. Question 21. A patient with end-stage liver disease develops ascites. The nurse understands that the primary mechanism contributing to ascites formation in this patient is
A.
increased hydrostatic pressure and decreased oncotic pressure.
B.
Decreased aldosterone secretion and increased renal blood flow.
C.
Portal vein thrombosis and systemic hypertension.
D.
Increased lymphatic drainage and decreased ADH secretion. Answer:
A.
Increased hydrostatic pressure and decreased oncotic pressure. This question tests your understanding of the pathophysiology of ascites in liver disease. The key concept is how portal hypertension and impaired liver synthesis contribute to fluid accumulation. In end-stage liver disease, portal hypertension, increased pressure in the portal venous system leads to increased hydrostatic pressure within the splanchnic circulation, pushing fluid out of the vessels. Concurrently, the diseased liver's inability to synthesize albumin leads to hypoalbuminemia, which results in decreased oncotic pressure. Both increased hydrostatic pressure and decreased oncotic pressure promote the movement of fluid from the intravascular space into the peritoneal cavity, forming ascites. Question 22. A nurse is caring for a patient with severe pancreatitis presenting with Cullen sign and Gray-Turner sign. The nurse recognizes these as indicators of
A.
pancreatic pseudocyst formation,
B.
retroperitoneal hemorrhage,
C.
biliary obstruction,
D.
pancreatic necrosis with infection. Answer: B. retroperitoneal hemorrhage. This question assesses your knowledge of specific physical assessment findings related to severe pancreatitis. The keywords Cullen sign, periumbilical ecchymosis, and Gray-Turner sign, flank ecchymosis, are classic indicators of retroperitoneal hemorrhage. These signs signify the extravasation of blood and pancreatic enzymes into the retroperitoneal space, often a severe complication of acute hemorrhagic pancreatitis. While pancreatic pseudosis, biliary obstruction, and necrosis with infection are complications, these specific ecchymotic signs point directly to bleeding. Recognizing these specific signs helps in identifying life-threatening internal bleeding. Question 23. A patient with severe traumatic brain injury develops syndrome of inappropriate antidiuretic hormone SIAD. The nurse should anticipate which fluid restriction strategy?
A.
Restrict oral intake only.
B.
Restrict total fluid intake to 800-1000 ml/day.
C.
Administer hypertonic saline to promote diuresis.
D.
Encourage liberal fluid intake to prevent dehydration. Answer. B. Restrict total fluid intake to 800-1000 ml/day. This question tests your knowledge of managing SIADH, particularly fluid restriction. In SIADH, there is excessive secretion of ADH, leading to water retention, dilutional hyponatremia, and often fluid overload, even in the absence of clinical signs. The primary treatment for SIAD is strict fluid restriction to promote negative fluid balance and increase serum sodium concentration. Restricting total fluid intake to a specified low amount, typically 800-1000 ml/day, is the cornerstone of therapy. Administering hypertonic saline is reserved for severe symptomatic hyponatremia and is not a general fluid restriction strategy. This targeted fluid restriction helps normalize serum osmolality and sodium. Question 24. A nurse is preparing to insert a central venous catheter. CVC? After the physician inserts the catheter, what is the nurse's priority action before using the CVC?
A.
Flush all lumens with normal saline.
B.
Obtain a chest X-ray to confirm placement.
C.
Secure the catheter with a sterile dressing.
D.
Document the insertion time and date. Answer. B. Obtain a chest X-ray to confirm placement. This question focuses on the critical safety steps after central venous catheter insertion. The keyword priority action before using the CVC emphasizes the immediate need to prevent complications. A chest X-ray is mandatory after CVC insertion to confirm appropriate placement of the catheter tip, typically in the superior vena cava A, and to rule out complications like pneumothorax or hemothorax before any fluids or medications are infused. Using the catheter before confirming placement could lead to severe adverse events if it is malpositioned or if a pneumothorax is present. Always confirm placement before you infuse. Question 25. A patient with a new diagnosis of myasthenia gravis is experiencing a myasthenic crisis. The nurse anticipates the administration of which medication?
A.
Atropine.
B.
Edrophonium, tensilin.
C.
Pyridostigmine, mestinon.
D.
For immunoglobulin, IVI. Answer. D. For immunoglobulin, IVI. This question tests your knowledge of managing a myasthenic crisis, an acute exacerbation of myasthenia gravis, typically caused by insufficient acetylcholine at the neuromuscular junction. While pyridostigmine, mestinon is a long-acting acetylcholinesterase inhibitor used for chronic management. In an acute crisis, the immediate goal is to rapidly reduce circulating antibodies. For immunoglobulin, IVIG, or plasmapheresis are the preferred treatments for myasthenic crisis to quickly modulate the immune response. Edrophonium, tensilin, is primarily a diagnostic tool. Atropine is used to counteract cholinergic side effects, not to treat the crisis directly. Question 26. A nurse is evaluating the effectiveness of treatment for a patient with metabolic acidosis. Which arterial blood gas, ABG, finding would indicate improvement? A. pH 7, 25, PaCO 250 millimeters of mercury, HCO 320 milliequivalent/L. B. pH 7, 38, PaCO 235 millimeters of mercury, HCO 324 milliequivalent/L. C. pH 7, 10, PaCO 225 millimeters of mercury, HCO 310 milliequivalent/L. D. pH 730, PaCO 240 millimeters of mercury, HCO 318 milliequivalent/L. Answer. B. pH 738, PaCO 235 millimeters of mercury, HCO 324 milliequivalent/L. This question assesses your ability to interpret ABG results, specifically in the context of resolving metabolic acidosis. The concept is recognizing normal ABG values. The initial condition is metabolic acidosis, characterized by a low pH and low HCO3. An improvement would mean the ABG values are normalizing. The ABG reading of pH 738, PaCO 235 millimeters of mercury, and HCO 324 milliequivalent/L represents normal acid-base balance, indicating successful resolution of the metabolic acidosis. The other options show either persistent acidosis, respiratory acidosis, or uncompensated acidosis. Normalizing the pH and bicarbonate are key indicators of effective treatment. Question 27. A patient with adrenal insufficiency is admitted in an Addisonian crisis. The nurse should anticipate administering high doses of which medication?
A.
Vasopressin.
B.
Insulin.
C.
Hydrocortisone.
D.
Glucagon. Answer. C. Hydrocortisone. This question tests your knowledge of the emergency management of an Addisonian crisis. The key concept is recognizing that an Addisonian crisis is a life-threatening acute adrenal insufficiency, characterized by severe hypotension, hypovolemia, and electrolyte imbalances. The primary treatment is immediate and aggressive administration of high-dose corticosteroids, such as hydrocortisone, to replace the deficient cortisol. Vasopressin is a vasopressor, insulin is for hyperglycemia, and glucagon is for hypoglycemia. None are the primary treatment for adrenal crisis. Prompt administration of corticosteroids is crucial for survival. Question 28. A nurse is managing a patient with acute respiratory distress syndrome, ARDS, who is requiring increasing ventilator support. The nurse anticipates which advanced therapy may be initiated if conventional ventilation fails?
A.
High-frequency oscillatory ventilation, HFOV.
B.
Non-invasive positive pressure ventilation, NIPPV.
C.
Continuous positive airway pressure, CPAP.
D.
Bilevel positive airway pressure, BiPAP. Answer.
A.
High-frequency oscillatory ventilation, HFOV. This question tests your knowledge of advanced ventilator strategies for severe ARDS. The keywords acute respiratory distress syndrome, ARDS, and requiring increasing ventilator support suggest that conventional mechanical ventilation is failing. HFOV is a specialized mode of mechanical ventilation that delivers very small tidal volumes at very high frequencies, designed to keep the alveoli open and maintain oxygenation and ventilation in severe ARDS when conventional ventilation is inadequate. NIPPV, CPAP, and BiPAP are typically used for less severe respiratory failure or to prevent intubation, and are not advanced therapies for failing conventional ventilation in ARDS. Question 29. A patient is being monitored with an arterial line. The nurse notes dampened waveforms despite flushing the line and ensuring proper positioning. What is the most likely cause?
A.
Catheter occlusion from a clot.
B.
Overpressurization of the flush bag.
C.
Air in the transducer system.
D.
Patient hypertension. Answer.
A.
Catheter occlusion from a clot. This question assesses your troubleshooting skills for arterial line waveform abnormalities. The keywords dampened waveforms and despite flushing the line and ensuring proper positioning are key. A dampened waveform indicates a loss of accurate pressure transmission. While air in the system can cause dampening if flushing doesn't clear it, a catheter occlusion from a clot is a very common cause, obstructing the free flow of pressure. Overpressurization would make the waveform appear artificially high or stiff, not dampened. Patient hypertension would simply result in higher, but not necessarily dampened, readings. Always consider a clot as a common culprit for dampened waveforms. Question 30. A patient with hypertrophic cardiomyopathy is experiencing chest pain and shortness of breath. The nurse should question an order for which medication?
A.
Beta blockers, for example, metoprolol.
B.
Calcium channel blockers, for example, verapamil.
C.
Nitroglycerin.
D.
Disopyramide. Answer: C. Nitroglycerin. This question tests your specific knowledge of medication contraindications in hypertrophic cardiomyopathy, HCM. The keyword hypertrophic cardiomyopathy is crucial. In HCM, the thickened septum can obstruct outflow, and vasodilators like nitroglycerin can reduce preload and afterload, which paradoxically worsens the outflow tract obstruction and can exacerbate symptoms like chest pain and even cause syncope. Beta blockers and calcium channel blockers are often used to reduce contractility and improve diastolic filling, while disopyramide can be used to reduce outflow obstruction. Administering nitroglycerin can be very detrimental in HCM. Question 31. A patient with a severe burn injury develops hypothermia. What is the most important nursing intervention to prevent further heat loss?
A.
Administer warmed intravenous fluids.
B.
Apply dry, sterile dressings to the burn wounds.
C.
Increase the room temperature.
D.
Use a forced air warming device, for example, bear hugger. Answer: D. Use a forced air warming device, for example, bear hugger. This question tests your knowledge of managing hypothermia in burn patients. While all options contribute to warming, the most important nursing intervention to prevent further heat loss is typically direct rewarming. A forced air warming device, like a bear hugger, provides active external warming that efficiently and rapidly raises the patient's core body temperature. Warmed fluids are also important for core warming, and dry dressings help prevent evaporative heat loss, and increasing room temperature provides ambient warmth. But active external warming is often the most effective and direct way to combat hypothermia in a burn patient due to their massive heat loss. Question 32. A nurse is caring for a patient experiencing status epilepticus. After ensuring airway patency, what is the most appropriate initial pharmacological intervention?
A.
Administer phenytoin 4.
B.
Administer lorazepam 4.
C.
Administer phenobarbital 4.
D.
Administer levetiracetam 4. Answer: B. Administer lorazepam 4. This question assesses your knowledge of the immediate pharmacological management of status epilepticus, which is a medical emergency. The keyword status epilepticus: continuous seizure activity or recurrent seizures without full recovery of consciousness between seizures, requires rapid termination to prevent neurological damage. Benzodiazepines, specifically lorazepam given intravenously, are the first-line treatment due to their rapid onset of action and effectiveness in terminating seizures. Other medications like phenytoin, phenobarbital, and levetiracetam are typically given as second-line agents for sustained seizure control after the initial benzodiazepine. Think benzos first for acute seizure cessation. Question 33. A patient with chronic kidney disease (CKD) is admitted with hyperkalemia, K+6, 8 milliequivalent/L, and peaked T waves on the ECG. What is the priority immediate intervention?
A.
Administer sodium polystyrene sulfonate, Kxalate orally.
B.
Administer regular insulin and dextrose 4.
C.
Administer a loop diuretic, for example, furosemide 4.
D.
Prepare for emergent hemodialysis. Answer: B. Administer regular insulin and dextrose 4. This question tests your ability to prioritize interventions for life-threatening hyperkalemia with ECG changes. The key clues are hyperkalemia, K+6, 8 milliequivalent/L, and peaked T waves on the ECG, which indicate myocardial instability and a need for immediate action. Regular insulin with dextrose, to prevent hypoglycemia, rapidly shifts potassium from the extracellular space into the cells, temporarily stabilizing the myocardium and lowering serum potassium. While Kxalate will remove potassium from the body and dialysis is the definitive treatment for CKD patients, these take longer to act. Insulin and dextrose provide immediate myocardial protection. Calcium gluconate would be given first if there were wider QRS complexes or dysrhythmias, but insulin/dextrose is for rapid cellular shift. Question 34. A nurse is caring for a patient with an endotracheal tube, ETT, who develops an SpO2 of 88%, absent breath sounds on the left, and epigastric gurgling, the nurse's immediate action should be to
A.
increase the FiO2 to 100%,
B.
suction the ETT,
C.
deflate the ETT cuff and pull the tube back,
D.
remove the ETT and manually ventilate with a bag mask device.
Answer. D.
Remove the ETT and manually ventilate with a bag mask device. This question describes a critical complication, accidental esophageal intubation. The key clues are SpO2 of 88%, absent breath sounds on the left, or bilaterally often, and most importantly, epigastric gurgling. Epigastric gurgling confirms the tube is in the esophagus and not the trachea. In this life-threatening situation, the immediate action is to remove the ETT and manually ventilate the patient with a bag mask device to ensure oxygenation and then re-intubate. Increasing FiO2, suctioning, or simply pulling back the tube will not resolve esophageal intubation and will delay critical oxygen delivery. This is an airway emergency requiring immediate extubation. Question 35. A patient with a large anterior myocardial infarction develops sudden onset of severe shortness of breath, hypotension, and a new holosystolic murmur best heard at the apex, radiating to the axilla. The nurse suspects which complication?
A.
Ventricular septal rupture, VSR.
B.
Papillary muscle rupture with severe mitral regurgitation. C. Left ventricular free wall rupture.
D.
Pericardial effusion with tamponade. Answer. B. Papillary muscle rupture with severe mitral regurgitation. This question tests your ability to identify a serious mechanical complication of acute myocardial infarction based on clinical presentation. The keywords large anterior myocardial infarction, sudden onset of severe shortness of breath, hypotension, and new holosystolic murmur best heard at the apex radiating to the axilla are classic signs of papillary muscle rupture leading to acute severe mitral regurgitation. The murmur radiating to the axilla is characteristic of mitral regurgitation, and the acute onset after an MI, along with hemodynamic instability, strongly points to this complication. A VSR murmur is typically heard along the sternum, and free wall rupture often leads to immediate death or tamponade without a new murmur.